I'm Paul Markovich, and this is Worthy, where we are creating the healthcare system we all deserve. Andy Slavitt has been an entrepreneur, a senior executive in the country's largest healthcare company, the director for the Centers for Medicare and Medicaid Services. He's also been a senior advisor to the President of the United States, as well as an investor, an author of the book Preventable, and he's also an award-winning host for his podcast, In the Bubble. In general, Andy's been a major force in healthcare for decades. And importantly for me, someone who appreciates and generously shares good wine. So Andy, welcome to the podcast. Thanks for being here.
You finally got to the important stuff.
I did. Yes, we have to get to the important stuff here. Well, listen, I would love to start by just understanding how you got into healthcare. What was your journey to get to healthcare?
Well, healthcare found me. I didn't find it, as often happens. In the late 90s, if we can remember back that far, my roommate in college, we were 10 years out of college, called me one day and said he was feeling numbness in his left arm. And he was pretty sure it was something serious. And sure enough, it was a brain tumor. And 4 months later, he had passed away.
Wow.
And his widow and twin 1-year-olds, Josh and Judy, moved across the country and came and moved in with my wife and I for the next year. And we spent the year trying to figure out how to help put their lives back together. And as happens with a lot of people, she spent 4 months trying to save his life. He incurred tens of thousands of dollars in medical bills. Even though he had good insurance, they were uncovered. And my wife and I spent the better part of a year trying to help them get on their feet. By the way, those kids today are in their late 20s. One of them is just about to graduate medical school in the summer.
Wow.
We helped them go to college, which was great. But it really sparked my interest in starting a company that would help people who were not covered for major healthcare events, who were underinsured, to get access to the same healthcare that people who have insurance get. And that's what led me to become an entrepreneur and start a company.
Yeah, tell me more. That company was called Health Allies. Tell me a little bit about that journey and that evolution and where it led you next.
Well, it was the late 90s, and internet was all the rage. And so it was a kind of a tech company for consumers, a little bit before its time, perhaps. But really was for consumers to come and get access to healthcare services that they weren't covered for. And it was, I suppose it was an early precursor to consumer-driven healthcare. In any case, ran that company for 4 years. And at the end of that time, we were acquired by United Health Group. I like to say every little boy's dream. And then certainly wasn't my wife's dream, because we were living in California at the time, and it forced us to move to Minnesota, where we lived for quite a while. And I ended up in a series of jobs over the next decade at United Health Group, including being one of the early people to start their Optum business, their tech and data and analytics business, and a few other things. So it led me about as far from the entrepreneurial journey as you can get into becoming a corporate, whatever you want to call it. And so that was my next 10 years.
Yeah. So you've had roles in the private sector and also in government. Maybe talk a little bit about how different the perspective is in healthcare from both of those angles, and what role you see each playing to help the healthcare system.
Well, I got to the government in a kind of funny way. I was there working United Health Group when the Affordable Care Act launched. And of course, I had some interest in the uninsured and underinsured, and I was pretty excited about the Affordable Care Act. And as some of your viewers and listeners may recall, it launched with a crash of its website. And it was kind of a major disaster for President Obama. And I did the only illogical thing you could possibly think of. And then I called Washington and said, hey, do you need any help fixing this?
So you ran towards the fire.
Towards the fire. Thinking, of course, that my call wouldn't be returned or would be discouraged or turned down. Paul, it turns out your call gets returned when you're the only person that calls. And that's what led me to lead the turnaround of the website and the Affordable Care Act, and eventually led President Obama to ask me if I wanted to leave my job and join the administration, which I did in 2013 when I came in to run the Centers for Medicare and Medicaid Services. And believe me, I thought I made a giant mistake because I knew nothing about government, knew only about the private sector, but was from the moment I got there, I was just incredibly proud to be there. Learned a lot there, and it was an incredibly dynamic experience. You're just, for one, you're dealing with large numbers of people, so you're dealing with tens of millions of people whose benefits depend on you, and then of course all the people who in the future are going to need Medicare or Medicaid or the Affordable Care Act. You want those programs to be sound and steady for them. And that was really kind of opened my eyes towards what it was like to try to make decisions in that kind of setting. And I think there's a rough parallel, Paul, in some respects to the private sector, in that you have a board of directors in the private sector. In the public sector, you have Congress,
Yeah.
who really represents the American people, who are really your shareholders. You have a boss in the real world, and in the real world, we had a boss, the president and the health secretary, and you kind of learn that different things make people tick, in the margin, in the context of being in government, but the same things hold: accountability, delivering results, focusing on excellence, really caring about people. I did something that I think I was the first administrator to do, and that I opened up my email account so beneficiaries could directly email me
Oh, wow.
if they had problems. And having your email address open to tens of millions of people who have problems, you can imagine the emails you get. But every morning, first thing I did every day was I read the emails that came in from Medicare beneficiaries, and it was everything from I'm in a wheelchair and I'm stuck in my kitchen because my battery has gone out and I have nothing to do, to
Wow.
my sister is disabled and is I'm fearful she's being abused in a complex, to I'm on an Indian reservation and I have no access to medical care or clean water. And these are often, by the time someone is going to email the administrator at CMS, they've probably gone through every other possible step. And so they're desperate.
Hmm.
And we would just jump on them like you do in the private sector, and
Right.
treated people like customers. And that was a little bit unusual for government. But so there was a little bit of bringing that kind of perspective to government, and there was a lot more of me learning how government really needed to function, and try to get there, not to impose private sector thinking where it didn't belong.
So when you look at the healthcare system, the American healthcare system in general, what gives you hope and what worries you?
I think we always have to be hopeful. Um, I think if you have something seriously wrong with you and you're in the United States, it's probably the best place to be. Um, and I think that's more true if you're well off and have good insurance than it is if you're low income, or you live in rural part of the country, or you live in certain urban parts of the country, or you've got a disability. But if you're doing reasonably okay, this is a good place to age, because you have a
Mm,
lot. What we don't have is we don't have enough good medicine to reach all the people that need it, and of course, it's very, very expensive. So what makes me hopeful is that with new technology, AI, data, many of the initiatives you've pushed over the years, Paul, um, there is a chance to innovate and bring some of the things that we know we do well in this country to more and more people. And I think you just got to be hopeful, looking at that. Um, to do it well, we're going to have to disrupt a lot of things and a lot of people and a lot of jobs, and I think we have to be okay with that. And that's one of the
yeah.
challenges I think you bring forward is, are we all willing to stand back and revisit the role we play, all of us, every single one of us, in the U.S. healthcare system, so that we can do a better job for people. And if we're not, I would put we really don't belong to be serving people the way we do.
I'm just wondering, I have my magic wand question for you. I think I might have gotten this from Harry Potter, but if I gave you this powerful magic wand that could change anything you wanted to in healthcare, what would you do with it?
I would say that the number one thing you can do, first of all, I think the magic wand question, if I could say, is a bit dangerous, because um, there's never one thing that's going to fix the U.S. healthcare system. We have a little bit of a track record of going from silver bullet to silver bullet, thinking that there's one thing that's going to fix everything, and there really isn't. But if I could do one thing, I would make sure every single person in this country had access to a longitudinal relationship with a medical care team, and we can define medical care team broadly.
Sure.
It may be a primary care doc. It may be a primary care doc augmented by technology. It may be a virtual relationship, but some sort of longitudinal relationship. Um, there's really good evidence that says that if people have been in a longitudinal medical relationship for at least 3 years, the cost of treatment goes down, the quality of their care goes up, and the quality of their life goes up. Um, and so, if we could somehow take this magic wand and use it so that we could solve some of the things that are standing in the way of that happening,
Right.
imagine, as you're listening or watching this, that you had someone that for the last 3 to 4 years just cared about you and thought about you and knew you and took care of you, or your mother or your father, uh, and that's the way things were. I think it would start to solve a lot of the problems
Mm-hmm.
that we have. Not all of them, certainly, but
Yeah.
it would be the one thing I probably would do.
No, as you know, healthcare's got so many things going on. There's no way there's one solution that will change everything. I should have been more specific because my magic wand is not limited to one item. So you can cast as many
Ah,
spells as you want. Andy, so if there's
well,
anything else
I
you'd
can
like to
work with
add, feel free.
I'm one of those guys who would get my three wishes and then wreck the first two, and then.
So you're just going to stick with the one. Okay.
I'm gonna stick with the one because I think
Yeah.
it is really important how we get at the inequities in the healthcare system. Um, feels like a real important and interesting challenge, and that's a complex challenge. But we do know that there are people that live within 10 miles of one another
Yeah.
that have 10 to 12-year difference in life expectancy. So it's we know what we're capable of. We're not delivering it to everyone. We actually know what disadvantages people, um, and we have to act on it. We have to be willing to act on it. And I would start with getting everybody into a longitudinal relationship, and and that relationship might look different depending on who you are and where you are.
Yeah. What do you think we need to do to get there, Andy? I mean, what does the government need to do? What's the private sector need to do? How do we get to that place?
Well, I think we do some things like this push towards accountable care organizations, the push towards capitation, the push toward those are all versions of pushing people
Right.
towards these kind of accountable relationships. I think if we wanted to think more long term, we might figure out how to insure people for a longer period of time. We might think about how to um, create and encourage these types of longitudinal relationships. And I think we might start to think about AI and what kind of role AI plays in this. I mean, I think people are starting to um, load their personal medical information into LLMs
Mm-hmm.
and let the LLMs get to know them better. And it turns out that the LLM could do a pretty good job of helping you. If you could imagine that happening in concert with a physician. So you had technology supporting you, you had a medical team supporting you. It may expand your ability to get there.
I'd love to shift gears and talk a little bit about Medicare since you were in charge of that program for a couple of years and obviously was the chief customer service agent for it based on opening up your email to all the beneficiaries. How do you view the Medicare program today and how it's doing?
Something fascinating, Paul. When I was there, it was the 50th anniversary of Medicare. It's
Mm.
now. We just had, I think, the 60th anniversary. Um, and so we did a bunch of survey work to understand what people liked about the Medicare program, what they didn't like about the program, what worked and what didn't. And it turned out that for many Americans, their 65th birthday was a incredible relief and brought real happiness because they felt like they were going to be finally taken care of by a program that they paid into their whole careers and their whole lives and had their backs. And that was incredibly special and meaningful to watch. And it turns out that Medicare has something like an 86% approval rating among the public. People really love this program because it fulfills a promise and it makes people feel safe. And I think one of the things that I learned when I was running the healthcare part of the U.S. healthcare system is I met my counterparts in other countries was they would say, we don't do everything in healthcare. We haven't by no means that we figured it all out or do we have it perfect. But we do is we try to take people's biggest worries off the table. We try to make it so that, people aren't worried that any little thing goes wrong in their life. And you can just imagine if you sit back, something health goes wrong in your life, the people aren't thinking about how am I going to get care and how am I going to pay for it. And that's something we don't do particularly well in this country. We created a level of underlying stress for people that for some reason, whether they have insurance or they don't have insurance, it's that maybe their doctor won't see them or they won't be able to find a doctor or they'll get the wrong treatment or something will go on or they'll get a bill that they won't be able to afford to pay for. And, I think we have come a long way with Medicare in those 60 years. It used to be that I think it was 13% of seniors used to live in poverty, below the poverty level before Medicare. So Medicare really has done a great job in that regard. And now it needs to modernize. It's modernized by covering prescription drugs. It's modernizing now by covering new technologies. It's still got some clunky and antiquated parts to it. You've got a hospital benefit, you've got a physician benefit, you've got a prescription drug benefit. Those things are kind of separate. You've got Medicare Advantage plans, which offer varying degrees of simplification and use. But I just think it's a program that we ought to celebrate, and we ought to celebrate it by improving it, and we ought to celebrate it by engaging the people that provide care into those systems.
Yeah, I have to say from my corner of the world that I've been living in for the last number of years, I do see all the benefits you talk about to Medicare beneficiaries, but I also see how administratively intense it is. I mean, just like as a private plan going through the Medicare bid process, for example, or seeing Medicare beneficiaries having more than 30 options in Los Angeles County to wade through and try to sort through with all kinds of different benefits. It feels like there should be an opportunity to make it a little easier for everyone and a little less administratively burdensome. Any thoughts on how we might do that?
The problem we have is that, any year, 2005, someone finds a problem with the program and so they create a rule or an administrative solution to it. And 5 years later, that's no longer a problem. But that rule still exists, and yet another problem happens, and so these administrative burdens layer on top of one another, and we've sort of lost the point. We've sort of lost track. I think the current administration, we tried this in our administration, really has a focus on trying to simplify things. Now, I will say this in defense of some amount of regulation. People have paid in their entire careers to be on the Medicare program, and the government has essentially outsourced this program to health plans and others. And so I think some of the regulations are in place just to make sure people get what they deserve, and it's that's not a simple task as well.
We had talked before about the importance of each person having their own personal longitudinal care team. I'm wondering if you see a way for Medicare to play a leadership role in moving towards that kind of model. more predominantly.
For those who aren't familiar with it, it essentially, creates an alignment between patients and medical teams to deliver their care, and they get paid on cost and quality. It's had mixed results. I think in some situations it's been quite positive. In some situations, it's got room to improve. But I look at these programs kind of the way you might look at any product, like an iPhone. It's not meant to be, we're living currently with sort of the equivalent of the iPhone 3 or the iPhone 4. And now we're at the iPhone 17. And the way Apple makes its products better is by listening to feedback. They want better GPS, or they want this, or they want that. And for CMS to do its job well, and this is hard for government, it's got to function the same way a product company does, and say we're trying to align people to physicians. Some things work, some things don't work. We need to keep doing the things that work. We need to fix things that don't work, and pay real attention to the market. And that puts a burden on all of us who work in the healthcare system to be highly communicative with CMS, and because they want to know what's working and what's not working. They want the data. They want to fix it. And this is a place where private sector thinking probably does help.
Yeah. I've personally had the sense, especially I think with the experience on the Affordable Care Act, that if we want to do something significant with our public programs or public reforms in healthcare, they're going to be much more likely to be sustainable if they're bipartisan in nature, which granted is not an easy thing in today's day and age. But I'm just wondering, first of all, if you agree with the premise that I proposed, and then also like how might we try and create a dynamic that is more bipartisan in terms of the direction of healthcare in the country?
Yeah, I absolutely agree with your premise. And the reason I think this isn't beyond our grasp is because most things that people don't want their healthcare to be partisan at all. The basic things people want is, someone in my family gets sick. I want to afford to be able to take care of them and get them back to health, period. Or even better, I want to afford to keep them healthy. I want to try to keep them healthy so they don't get sick in the first place. Those are universal wants and needs. And when we stop playing politics and you really start talking to people as people, you realize there's broad consensus. Like that statement that all I want to do is be able to care for people in my family if they get sick or keep them healthy. It's like 85% of Democrats, 75% of Republicans agree with that statement. And so you have to stop with the arguing, and you have to go grasp and reach for that common ground.
One of the things that I've been impressed with and gives me hope for government programs, both present and future, is that we've been able to attract some high quality leaders to healthcare leadership roles in the federal government. People, including you, but also people like Seema Verma and Dr. Oz today. I'm wondering, why do you think that is, and how do we keep that track record going?
I think it's really important that both things happen, that people go from the private to the public sector and people go from the public to the private sector, because you get and for the same reason, people should be going from health plans to hospitals and hospitals to health plans, because it's very easy to demonize what you don't understand. Or a perspective you don't have. And, one of the things that I think you do a great job in your work pointing out is there's really not one bad guy in this system. But from where you sit, if you sit in the health plan, it feels like hospital costs and pharmaceutical costs are what's driving everybody crazy. And if you sit in a pharmaceutical company, it's the PBMs and the insurance companies that you think are at fault. And if you sit in a hospital, then you're really frustrated with the insurers and the government. And if you're a doctor, you probably are pissed at everybody because it's all coming down on you pretty hard. And that leaves patients kind of going, where are things, and why am I being spun around like this? So I found it, very fortunate in my career that I got to have multiple perspectives, just being in the private sector, being in the public sector, being now on the investing side. Where you really see that there are a lot of people that are trying to do a lot of good things, but they just don't understand one another, don't communicate very well. And no better way to fix that
Right.
then go do a stint in government. Go do 2 years, go do 3 years in government. And if you're watching this or listening to this and you're thinking, and you're at that point in your career when you're thinking, what do I want to do to make myself an incredible athlete in my career? If you're working in healthcare, I'd say go do a couple years stint
Yeah.
in government. Or if you're in government, go do a few years in the private sector.
Yeah. Nothing creates empathy like walking in someone else's shoes.
That's right.
Well, you mentioned you're an investor now, and you're the co-founder and general partner at Town Hall Ventures. And one of the things I've been really impressed by, and because it might be unique, is how much you are focusing on improving the health of Medicaid beneficiaries. I'm wondering what prompted you to co-found the company and also focus on that agenda.
Well, one of the things that, if you look at where the solutions to our problems are going to be in healthcare, we've talked a little bit about policy, but there's another one, and it's one that you're personally very familiar with, which is innovation. And the question is, it's if you look at what we're uniquely good at as Americans, where are we uniquely good? It's in innovation. And so the question is, are we innovating in the right things? Because for a long time, you could say that most of the places we were innovating where we would have a better Fitbit, so that people can self-actualize better, or an Oura ring, or a Whoop, or a
Yeah.
Boop, or a Smoop, or whatever the latest device is. And that's solving some people's journey towards better sleep and better health. But if you look at kind of a step way back and zoom out and say, where are the real problems in healthcare? What do we really need innovation? It's a better mental health system in urban communities. It's better answers for rural communities to get access to care. It's a Medicaid program that gets people access to specialists. And it's kind of fun to think about how these really thorny problems can be solved with elbow grease and innovation and a little bit of capital and some technology. And those are the tools we try to bring to this problem. And we find that it's sometimes harder for larger incumbents to innovate on their own. And so finding startup companies that can work very effectively with larger incumbent, whether they're insurance companies or hospitals, to solve some of these problems, whether it's in Medicaid, which is one of the places we work, or whether it's in other areas like rural health, like mental health, like care for the frail elderly. That's really fun.
How did your experience in overseeing Medicaid differ from Medicare? Obviously, it's a shared program between the federal government and the state governments. And yeah, well, we'll start with that. And then I'm curious as to how that has informed some of the places you're investing today.
When I was there, the big thing going on in Medicaid was we were in the process of Medicaid expansion, which, for those of you who aren't familiar with what that means, it's really was passed in the Affordable Care Act so that people who were low income could get access basically to medical care, even if they weren't disabled or they weren't mother and children, or seniors retiring. And it's been, without a doubt, one of the most successful programs in the history of all government programs, and that tens of millions of people, 10 million plus people got covered. The rates of cancer went down, the rates of heart disease went down, but the rates of home ownership went up. The rates of medical bankruptcy went down, payday lending went down, all because we offered people who were in the toughest position in their lives and working often multiple jobs, access to some basic medical care. So it was, for me at the time, Paul, it was a lot of negotiating with Republican governors in Indiana and Alaska,
Right.
and other states who looked at this program and said, objectively, this is pretty good for my state and my people, but I don't really want anything to do with a Democratic program labeled Obamacare. So it was a lot of working with states to figure out what was right for them, and not having a lot of pride of authorship in how this got rolled out.
What you talked about how that expansion help people? What else do you see working well in Medicaid, and where do you see potential challenges with the program?
People, there's a large number of people on Medicaid who are living with a disability,
Mm-hmm.
or they're frail elderly, they're seniors, or they're dual income, meaning they're dual eligible, meaning they're both low income and fixed incomes, seniors. And a lot of these people are homebound. So one of the innovations that Medicaid does incredibly well is something called home and community-based services. It basically providing access to people who come to people's homes and take care of them. And increasingly, that's a very effective program. And in some ways, it's the only way to take care of people. So as we
Yeah.
think about how we treat people, how we care for them on a day-to-day basis outside of the doctor's office, we've got a lot we could learn from the Medicaid program, who's been doing that very effectively. Now, it's been done with a lot of brute force and labor, and it needs to be done with a lot more technology. But I think that's coming.
We picked the title Worthy because we describe our nonprofit mission as trying to create a healthcare system that's worthy of our family and friends and sustainably affordable. What would you like to see the federal government and the private sector do to try to get to that standard in the Medicaid program?
I think the biggest challenge with the Medicaid program is there are a lot of physicians, because Medicaid reimburses at a lower level, that and patients are complex, that don't accept Medicaid patients. And so sometimes if you have Medicaid coverage and your child needs to see an allergist for their asthma, it can be well over 90 days before you can find an allergist for your kid. And I think that's true with a lot of specialties. There's a lot of things that just aren't covered under Medicaid. And so, I would like to see us make a commitment to make this program work very much like the Medicare program does. And that's going to mean a little bit more reimbursement. And it's also going to mean going back to something we talked about earlier, which is giving people access to a regular, routine, longitudinal source of care. And I think if we, to come back to sing that note again, we do that, we're going to keep people from needing to see specialists more, because they're going to be seeing the primary care doctor more and they're going to be taking care of them. But then that's also going to mean that if they do need to see a specialist, first of all, there should be more that primary care doctors can do because of technology.
Right.
And that we find a way so that states make a commitment that it won't take 90 days for someone to find a specialist again. And that's one of the things we pushed on really hard when we were running the Medicaid program was to force states as much as possible to accept metrics like that.
So, Andy, what else would you like to share that I haven't already asked you about when it comes to healthcare in America?
We've talked a lot about some of the policy areas. We've talked a little bit about innovation. We've only touched really briefly on cost. And as I've read in many of the things you've written, and as I know you've been focusing on for your career, the affordability question may be the most sizzling hot and an important question. And so what's behind that? What's behind all these costs? Well, we have a higher unit cost than anywhere else in the world. It costs more to go to a hospital. It costs more to get a prescription than it does in other parts of the world. And we have a sicker population. We have a sicker population because we have an imbalance in how often we use preventive care and take preventive care of people. And a lot of people don't have access. And it doesn't mean that if they don't have access, they don't consume medical expenses. It means that they consume them in kind of the wrong places. The emergency room, the hospital, instead of in their home, instead of in a clinic, instead of in their community where it's more comfortable and when they're healthier. So we're going to have to get at that. There's no way around it as this population continues to age, that we're not going to have to figure out how to keep people out of the hospital, take care of them at home, take care of them in their communities, and find lower cost labor. And the truth is, I'm a big fan of saying there's a doctor that doesn't need to do everything. A lot of stuff can be done by nurse practitioners. A lot of stuff done by nurse practitioners can be done by community health workers. A lot of stuff can be done increasingly with AI support. Um, and if we pretend like cost isn't a factor here, then I think we're really missing the boat. And I think you've been really a big leader in our country at helping point out how we need to take on affordability.
Yeah, thanks. I think there's clearly needs to be a mindset shift in the industry to thinking that we have a cost problem rather than a revenue problem. I think there's a lot of players and participants in the system that keep thinking they need to get their reimbursement higher as a way to solve, but that at a system level, it's just not working. Well, listen, Andy, I want to thank you very much for being here today and participating in this, but also more importantly, for all the contributions you've made to healthcare over a whole lot of years. And so thanks so much for everything.
Well, you're so kind to have me on, and I really admire what you're doing, Paul. This effort, I think, worthy. It's so unique. It's so unifying. It's something that I think everybody can relate to and grab onto. And I'm so glad you're doing it. And anything that I can do to support you, as you know, I will do.
Thank you so much, Andy. Appreciate it.